Okay, guys, are we good to make a start, do you think? To make my life more complex, the two colleagues who've got with me tonight both have the same name. Uh, so I was racking my brains on how to determine which Lisa I would be bringing into the conversation at the appropriate time. I could tell you I thought of all sorts of nomenclature for both of you, none of which were going to satisfy your needs nor mine. So I'm literally going to go for Lisa C and Lisa M. Lisa C, would you like to just introduce yourself to people joining in on the webinar tonight?
Yeah, sure. Hi, my name's Lisa Collins. I'm a clinical team leader for 360. Do you want me to give some background?
I think if you would just explain, as we start to talk about physical health and ADHD, your background, where you came from, it is particularly pertinent to this agenda, which is why I very much asked you to join us tonight. So yeah, go on, explain that.
So I'm a mental health nurse for about 20 years, but for 12 of those years, I've been working in substance misuse, health injustice, so offender health. So working in prisons. And then for the last 8 years, I've been working with female opiate users in prison. So lots of alcohol, lots of opiate use.
Thank you. And then Lisa M, known to a lot of people who join us on our webinars. Would you like to introduce yourself, Lisa?
Yeah. So my name's Lisa Mangle and I'm one of the founding directors alongside Phil of ADHD 360. So I've got quite a wide background. So my nursing career started in adults and paediatrics, and then I moved with my degrees in psychology into ADHD 22 years ago. But and in that 22-year career, I've looked at research and medicine and worked in the pharmaceutical industry, and then helped set up ADHD 360. But throughout that time, I've been really passionate about the whole person and not just the ADHD part of that person. And I think sometimes health goes really wrong when you are so specialised that you're only looking at one niche bit of a person. And so this is a really passionate area for me, because it is about the well-being of the person within the family. So I'm really excited about tonight and the questions that you might pose and the topics that we might discuss. I always love these webinars.
Thanks, Lisa. Lisa squared. Thanks to both of you. A starting place to throw I like to start these events by throwing a pebble in the pond and starting a discussion. I think tonight I'm going to throw a grenade at the pond. and Lisa Mangle and I and a couple of colleagues were in America doing some research at the back end of last year, and we were in conversation with one of our trusted colleagues, Professor who specialises in the psychiatry of the whole piece, not just ADHD, Rakesh Jain. And we were talking about the very often quoted statistics of the impact of ADHD on someone's overall end-to-end life expectancy. And there's a very shocking and disturbing set of data that is often quoted around shortening of someone's life because they've got ADHD. And the latest research says that's about 13 years less lifespan if your ADHD is untreated or poorly managed. And Lisa and I have been forming opinions about that for some time, and taking that and discussing it with the likes of Rakesh. We were discussing that, well, what is it that makes somebody with ADHD be at risk of having a slightly shorter lifespan? And we knew part of the answer. What we were doing is exploring it. Let us explore it all together tonight. How does being impulsive, or how does having inattention have that effect on you? And the bottom line is, directly, it doesn't. Those classic DSM-5 criteria for ADHD do not directly mean that you are going to have a less lifespan. But what they do correlate to is an awful lot of lifestyle factors that then can affect you if we don't address them. And when we started to explore those, we started to formulate this idea of ADHD below the neck. And that's what tonight's all about, is what are those factors and why does that affect overall health and well-being for the patient with ADHD, beyond treating the inattention, the hyperactivity and the impulsivity. And I think it is fair to say, to echo what Lisa's just said, is that it's exciting. And it's exciting already to be part of a change agenda along these lines. So let me explain what some of the things are that we're talking about. And yet only yesterday I was talking to the parents of a young 16-year-old child who's coming to our clinic this week. And we were talking about her ADHD. And I just threw out the question that we would always often ask is, having not met the young lady, I said, is she carrying any excess weight? Yes, she definitely is carrying weight. And there's your first clue, is that people with ADHD are generally often carrying weight. And that's down to an impulsive diet, a lack of planning, a lack of appreciation of the health of food. And that manifests on to inappropriate diet, fast food, and carrying weight. Carrying weight per se it is not healthy, it's not brilliant, but as you get on in life, and I look at this, I'm probably going to be the oldest person on this webinar, I'm certainly the oldest in this group speaking. That leads to, excess weight leads to diabetes, and a lot of our patients are pre-diabetic. Can we reverse that by treating the ADHD, having a better diet, better planning of shopping, and better food? Yes, we can. Carrying excess weight and having a rubbish diet, fast food, fatty food, increases cholesterol. If we've got increased cholesterol, we're carrying weight. Is there an increased rate of heart disease and heart attack? Yes, there is. Can we reverse that? Yes, we can. And you can see a picture starting to build up. The risk of stroke is higher for patients in that scenario of excess weight, a poor diet, excess cholesterol, excuse me, and so on. And we start to build a picture. We'll get into the details of it in a bit. Lifestyle-wise, people with ADHD are more inclined to abuse substances to normalise their life, rather than having taken substances, cocaine, heroin, cannabis, for a high. They're taking it to normalise life, and that's why Lisa Collins is here to talk and help us understand some of those behavioural lifestyle that you were seeing in the prison setting, Lisa, where it was untreated ADHD that got a lot of people in prison, as opposed to being a drugs baron that was importing cocaine from Guatemala and selling it on the streets of Sheffield. There's a lifestyle piece to this. We talk about sexual health and impulsive sex, excuse me, that is not thought through, that the risk of sexual disease and transmission of sexual disease because of impulsive sex without planning, without the use of condoms, inappropriate partners, having sex to make yourself feel good when you've got a low self-esteem and you're quite anxious about how you present in your own human body, is not an appropriate lifestyle that can lead to some very poor outcomes. And what we're building is a picture that says, wow, this sounds really tragic and horrible, and that's my grenade into the pond. But if we pull it back, we can deal with all of that by actually treating ADHD really effectively. And that becomes our goal. So our 2024 mission is to do that. Lisa, can I bring you in at that? But Lisa Mangle, I'll bring you at that point.
Yeah, I was just going to give a few examples really of patients that I've seen recently. So I've got one lady in my mind who was really, she's a private patient of ours who was really worried about cost of medicine. Anyway, she started medicine, and when I followed her up 3 weeks later, she came back with this app that she'd got where every purchase that she'd made, she could see where she'd spent all her money for that month. And she said actually what she'd realised was before treatment she'd had a McDonald's every day on the way home from work because she just could not food plan and food prep and make sure she went into a supermarket and bought healthy food. And so she'd gone from having a really calorific meal after work to just having one in that month where she'd been on treatment. And over that time of titrating and optimizing her treatment, her BMI had started to reduce, not because of the side effects of medicine. She was still eating, but she was eating healthily. And it was just really lovely to be able to see someone be able to live a life in a way that was healthy. And I know over time, we've saved years for that lady and saved the risk of other conditions like type 2 diabetes, etc. But she'd got no idea that her eating habits were linked to her untreated ADHD. You know, she just thought she was lazy, and that's absolutely not the case.
And there was a great comment from her, wasn't there, as you relayed the tale to me a few weeks later, about the implications of finance on that, and
she
how
actually said she'd got money left in her bank at the end of the month, which had never happened before. You know, she said, she said, I'm always, you know, overdrawn. But she said it was the first month that she actually got to payday and there was money left in her bank, which, you know, for her was a game changer. You know, she could change her lifestyle and change her hobbies and her fun activities because she could. You know, she could now.
I've saved the money to cover the cost of my medication from my McDonald's bill alone, and I've still yet to tot up what Kentucky and Pizza Hut will costing me.
Yeah.
So we can reverse these things, and that's the positive message that will be a theme all the way through tonight's webinar, and then all through the year as we work on this additional campaign. If I bring Lisa Collins in for a second, Lisa, you've got this immense experience of working with especially women who've really cocked it up and ended up in prison in the secure estate. And if we switch the lens from, and we'll go back to the domestic side of things, but let's shift the lens a little bit into substance abuse. What were you seeing in your profession in that regard that was connected to perhaps untreated or poorly managed ADHD and substance abuse, which is an extreme, obviously?
I mean, it wasn't just unmanaged, it was undiagnosed and untreated. You know, we say 25% of the female offenders that I was working with were undiagnosed, untreated. Life was just chaotic. Lots of drug use, lots of cocaine use, lots of shoplifting, lots of impulse shoplifting to fund cocaine use, lots of health conditions, so comorbidities, just really, really sad, actually, really sad. I had a similar story, actually, Lisa, to yours today, with a private patient who had tried everything to try and manage his drug use, and was bizarrely microdosing with mushrooms to try and manage his ADHD symptoms, and was paying something like £300 a time to try and microdose these mushrooms to manage his ADHD. It wasn't working. We've started him on treatment. I did a 3-week follow-up today and he has never felt better, and he's, you know, quids in. But yeah, what I was seeing in terms of drug use in prisons was just, yeah, really sad, really chaotic, and lots of health conditions untreated.
And that sadness, you know, should and does drive us to actually to where we want to be. And I was coaching a separate set of parents this week who were bringing their child into our clinic, and we talk about setting goals. And I know that the three of us, when we're talking at the coaching level with our team, the most important thing we can bring into somebody's life with treatment is not being able to get through the 3 R's better or pass your driving test or get through your A-level. It's actually to be happy. And the greatest gift we've got as a clinical team is to bring happiness into someone's life. I'm going to change the subject to something. We'll come back to it, I'm sure. We will from the prison setting. Let's take it right back to basics, Lisa. When we first started working on what we call the public health agenda, the below the neck piece, I'm going to go to the chap in Leicester that we discovered was hypertensive. And I can never remember how old he was, and I know you can.
Yeah, so this guy was 27, never had his blood pressure taken in his life, and And so, you know, one of the things we always do is a baseline, you know, height, weight, blood pressure, pulse. And his blood pressure was something like 180 over 120. And I thought that's a bit of an extreme white coat syndrome. What's going on? And he, as I say, he'd never had his blood pressure done before. And, you know, I'm mindful even 5 years ago that untreated ADHD can lead to anxiety, poor eating, poor lifestyle, lack of exercise, etc. So we all, Phil and I, have built a business on being brave but safe. So what we decided to do was do this guy's blood pressure every day. And we always provide a blood pressure machine for our patients. So he did his blood pressure every day for a couple of weeks and sent it in. And it came down slightly, but not significantly. So I decided that we would carry on doing his blood pressure every day, but we'd start him on treatment. So we started him on a stimulant treatment and did a daily blood pressure and pulse. And over time, and it was probably about 12 weeks of titrating and optimizing his medicine so that he could live his best life. His baseline blood pressure had reduced to a spot on normal blood pressure for a 27-year-old. And you could see it coming down week on week, and his blood pressure ended up at 120 over 80, which is perfect. You know, but this guy was 27, never had his blood pressure done before, was probably heading for a heart attack or a stroke by the time he was 40. And that would have been really sad. And yet, just by treating his ADHD, we then normalised his blood pressure, which took the pressure off the rest of his body. And nobody would have thought of that. You know, everybody probably would have thought, right, he's got a blood pressure, we're never going to treat him with a stimulant. But in actual fact, it's probably saved his life, you know, by treating him with optimized medicine.
Got a couple of questions on the chat that we'll address, and then I'm going to come back to Lisa Collins on and I'm going to the link, Lisa, just so you're getting ready. It's going to be the anxiety that young man had as caused by his untreated ADHD, what you used to see in people in terms of anxiety and self-esteem when you were with the ladies in the secure estate. People are asking us, what's the agenda for tonight? It's very clear what the agenda for tonight is. It's looking at the impact of ADHD on physical health, the body below the neck. Psychiatry is traditionally about above the neck. It's about the brain. What we're talking about tonight is the effect of ADHD on the human body and lifestyle per se. ADHD below the neck, physical health, often called the public health agenda, and NHS and social services working consistently in the community to reduce smoking, to reduce alcohol, substance abuse, bring hypertension under control, bring diabetes under control across the community. And what we're saying is it's okay doing that from a purist perspective, but actually if we start to think about treating something like ADHD properly, you have a huge impact on those things from a holistic perspective, not just by targeting them completely. A standard program for diabetes will not look at what is the cause of that person's eating habits being so poor. A standard program for smoking cessation is just saying stop smoking and we will give you tricks and tips to do that. Not why is someone smoking, to alter the dopamine levels in the brain through the use of nicotine and being addicted to that, rather than using appropriate medicine. And these are campaigns that are heavily invested in across society, but actually sometimes are not looking at the root cause. So that's the agenda for the meeting, and making that very clear. Lisa Collins, coming back to you then. Lisa introduced this chap's hypertension, this 27-year-old lad, and no one had checked his BP, because as blokes you just don't get your BP checked. Often women get theirs checked when they go on the contraceptive pill, or there's something going on along those lines. Men don't, and there we were. And his ADHD was very much about his anxiety and his whole dissatisfaction with life and low self-esteem, making him even more anxious about what's tomorrow going to bring me because today was really hard, and so on. What were you seeing when you were dealing with women who'd really got it wrong and ended up in prison?
So just increased. So with increased anxiety in women, we're seeing, particularly in prisons, we're seeing more illicit use. So people trying to treat their own symptoms. We saw lots of self-harm, lots of ladies that were suicidal at this point, and like I say, lots of illicit use. In terms of physical health, we saw ladies with high blood pressure, ladies with sleeping problems, struggling to eat. So all these sort of overlapping symptoms with ADHD.
You mentioned sleep there, and when we were working out what were the key indicators for us in terms of what to tackle on this agenda for 2024, sleep starts to feature quite heavily, and I think we all know that sleep is a debilitator if you don't get it. I used to be a shift working policeman, and at the end of a week of nights, you know, the ability to function is a real struggle. We're all going to struggle without sleep. So we're measuring sleep as a baseline, and we're looking to improve sleep as part of treatment. And the impact of not being able to sleep really is quite severe. And you talked also, and if I bring Lisa Mangle back in, you also talked about self-esteem and people feeling quite low about themselves. And Lisa, we talk about in the public health agenda how a low self-esteem can be quite destructive, and people, especially adults, but not uniquely adults with ADHD, who are struggling with their self-esteem, really struggle to function effectively in society and make the best of themselves. And I think, you know, we see that daily in clinic, don't we? And I remember that. Do you remember the young girl from who came to see you in Sheffield, who was ADHD and autistic, wouldn't shower, wouldn't have water on her body? Do you remember her tale?
Yeah,
you know, do you want to just relate some of that, because that links into the whole self-esteem piece?
Yeah, so she was so excessively anxious because of her untreated ADHD. She literally couldn't have a bath, couldn't have a shower. They lived by the coast. She couldn't go to the beach, couldn't go in the sea. And her anxiety was so high that her obsessions and her fixations were also impacting her life. And I'll never forget, once we'd treated her, they ended up sending us a photograph of her in the sea. Do you remember, Phil?
Yeah.
And we looked at it and thought, crikey, this is a girl who couldn't even have a shower a few months ago. And now she's going in the sea and coming out and getting covered in sand and living her best life. And that self-esteem piece is, and it's one of the questions we ask during our assessment, what's your self-esteem like? And 99% of our patients are really impacted by low self-esteem, and that runs into everything that you do in your life, your work, your home, your social life. If your self-esteem's affected, it impacts everywhere. And we can then see, once we've treated their ADHD, that the confidence increases and they can see that they're reaching their potential. That's not going to happen overnight, but it is a medium to long-term goal that we look for in our patients. Really important.
Let's put some structure to this now that hopefully we have set the scene and we've built that there is a correlation between ADHD and these physical health things that we can start to actually have a positive impact on. Can I ask our invigilator, Kristen, to show the Michigan model for us, please? Thanks. Now there's a story behind this. We'll come to the story because you'll all be looking at the model now. Working with some very leading professors on this subject and associated subjects. We've picked 5 of the top physical health things to work on for 2024. Alcohol abuse, diet, weight and diabetes, smoking cessation, disordered sleep and hypertension. And I would say with alcohol abuse, that's including substance abuse. It's the abuse of something that is unhelpful. We've called it the Michigan model out of respect for Professor Tim Willens, who sat down with me for a good 3 or 4 hours helping me work this model through as to what should be the priorities for the agenda for 2024 for us. And new patients onboarding to join us now are asked specific questions excuse me, about alcohol and substances, their diet, their weight, smoking, sleep pattern, and of course we're always taking those regular readings for blood pressure and hypertension. And people in Michigan are renowned for using the palm of their hand to describe where they live, because Michigan as a state in America resembles the shape of the palm of a hand. And Professor Tim Willens, who helped me work this up, who is an expert in ADHD and substance abuse, is from Michigan. So we've called it that in deference to Tim, who's been instrumental in helping us take our understanding to the next stage. And if I come back to Lisa Collins now, and if we take the diagram down for a second, Kristen, thanks. If I come back to Lisa Collins now, Lisa, talk about alcohol and the effect of alcohol that you've seen in your ADHD career, and then we're gonna start talking about tips and what we can do about things.
Sure. So alcohol in females. So AA have actually recently put some statistics out now that they are saying that 25% of the patients they're seeing in AA are diagnosed with ADHD. So that's massive, isn't it? That's a big proportion. What we were seeing in prison is that ladies were coming in, they'd been using alcohol, often alongside cocaine. This was having a detrimental effect on family life, on their physical health, on their mental health. Coming into prison meant total cold turkey from alcohol. So ladies at this point would be really very poorly. We were able to treat that, but it's really dangerous. So it had a massive impact in prison, actually. There was, some ladies were still managing to illicitly use hooch, which is like an alcohol that can be made in prison. So again, very dangerous. We did have AA, actually. So we did have interventions within prison. So they were able to come in and get some structured support. But in terms of what that was doing to ladies that were coming into prison, often it meant that families were being removed, their children were taken away, then there was excessive potential cocaine use on top of the alcohol. It's just terribly sad. And now that we know that 25% of those patients in AA have ADHD, it's just massive.
Yeah, it's a profound effect. And as we switch into things that we are doing to increase the effect of that, we often lose sight of the profound effect of something that for the normal society, if there is such a thing, is normalized in behavior. Having a drink is normalized. But for the acute need of people who are medicating themselves through desperation or dealing with anxiety through desperation, this is not normalized. Lisa,
I think the thing to think about with alcohol use is that most people drink alcohol to socialize. People with ADHD drink alcohol to shut this brain up, to shut this hyperactive brain up. So actually, I can have a conversation. And what I see a lot is that they may have a couple of glasses of wine or a couple of beers, and this brain does shut. But then we don't stop at that. We keep going, and that's when it becomes destructive. And what I find is in my patients, and it's not always a conversation that I have, but they find that they don't need a drink anymore because the treatment for ADHD actually slows the brain down and stops the brain being hyperactive. So they come to the next follow-up and say, I've not had a drink since last time, so because they don't need it. They're not self-medicating with it as opposed to socializing like non-ADHD people do. And it's really important that we consider alcohol use and nicotine use, because it has a massive impact on the body. You know, we had a training session a few months ago from a cardiologist. And for me, I always say every day is a school day. And what he said was that reducing your nicotine use is not where we're at. 1 cigarette a day can be just as detrimental as 20. So what we need to do is stop people smoking, not just reduce the nicotine use. And I never knew that. I never knew that that was a statistic that we needed to be doing. And so it is something that we've introduced at 360, that we ask a baseline nicotine use, and then once we've optimized the treatment, we can go back and say, how's it going? Have you managed to stop? You know, have you managed to get some treatment from your GP, etc.? Because that's all about being able to plan and organize and stick to a routine. So yeah, it's really important that we look at substances and alcohol use and where it's going once we've optimized the treatment.
And if we take that below the neck, alcohol abuse leads to liver damage, and liver damage leads to premature problems. And there's the link. There's a couple of interesting questions in the chat. The first one I'm going to pick out is, do any of the ADHD 360 staff have lived experience? I promise you, most of us have lived experience. Lisa and I, especially, Mangle and I especially, we have people in our family who have ADHD, our extended family who have ADHD and autism. Lisa Collins, I don't know enough about your family to be able to answer that on your behalf. But proudly, as an organisation, we also employ a heck of a lot of people with ADHD and autism, both clinicians, front office staff, inquiry staff, and we're incredibly proud of the fact that we have lived experience, not just at home, but at work every day. And we know that we've changed lives in many different ways. So yeah, lived experience is strong. The other question was, well, okay, so we've got these problems. What the hell are the tips? What the hell do we do about it? And I think that's a really great question. There's no point in having an educational program that just tells you how bad it is. What we've got to actually do and tell you what the risks are. What we've got to do is take that somewhere into something positive. Now, the very first thing we would say, any of us, is that your ADHD treatment plan is specifically designed to reduce the effect of these things on your body. There was another question about brain chemicals. The ADHD brain is not using dopamine as well as it could or should do. That's the simple fact of the ADHD brain's pathway and deficit. If we increase the dopamine to a point where it's more effective, we have less of the symptoms of ADHD: inattention, hyperactivity, impulsivity, to give it the standard manual words. If we do that with medicine, and that medicine is titrated by an experienced clinician, and we know what we're doing with it, everything's fine. That's a happy days situation, and everything's on a good pathway. But if we're not doing it, we've got a problem. Or if we're doing it in a way that is not healthy and sustainable, we've got another problem. So the point of a treatment plan is to either get that dopamine to where it needs to be so we can have a healthier lifestyle, and or stop you doing things that are inappropriate to get your dopamine to where you think it should be. The moment we start to follow our treatment plan, and the moment we start to actually notice the difference as measured with hyperactivity, inattention, and impulsivity, we start to see differences in the physical health things that we're discussing. So, for instance, if I use a soft and easy example, caffeine is abused by the ADHD community until such times as their treatment is on point. Because what caffeine does is stimulate that dopamine production. And one of the things we ask our patients to do is, can you cut down, reduce, if not remove, caffeine from your diet so that we can see the honest effect of medicine and not medicine plus caffeine? The moment we get that impact, we start to see where the medicine's working and what we need to do. And that's exactly the same with substance abuse. It's exactly the same with alcohol abuse. It's exactly the same with those other things that we've been discussing. And then as your treatment pathway kicks in even more, we find the patient able to organise their shopping, the young lady that was going to McDonald's. We find able to actually organise and cook better meals and plan and relax a bit more and start to feel a little bit happier, a little bit increased self-esteem. So eating healthier, not eating rubbish, and doing life properly and to a fulfilled level. So the biggest tip that comes out of any of this is actually, first of all, go and get your diagnosis, get that done, get that out of the way, jump into a treatment plan with a clinician, a trained clinician who's going to help you. And then the third top tip is follow that treatment plan. Stick to the treatment plan and don't try and work out what's best for you yourself. Trust your clinician. And if we do that, we start to actually then work on smoking less because we need less, cutting out smoking because we no longer need the dopamine rush from being addicted to something and something that's harmful. We would encourage no caffeine. We would encourage a better diet, but we'll find that coming anyway. We'll be measuring your weight and we'll be measuring BMI for adults. So we're doing those things regularly. We then should see hypertension reducing. We should see weight reducing. We should see, therefore, if we were to test it, less liver fat, a healthier liver, coupled with less high blood pressure or lower blood pressure. We're starting to see a difference. The other things to start encouraging is you start to get happier and on top of life a little bit. And for both of the Lisas, the forthcoming app, we're looking at how we can encourage exercise programs through that, and how we can encourage our patients. You might only take 20 steps today on your stepometer in your phone, but if you took 25 tomorrow, we've made a difference, and that could build up and so on. So we're looking at how we can encourage and help overall health that way. In terms of diet, someone's asked the question, do we have healthy diet plan or ADHD recipes? There's a whole suite of webinars we did last year on healthy diet, and they're available. They've all been recorded with a dietitian who specialises in ADHD, and I would encourage you to go to those things. So as I've battled through the most important tip is get assessed and get diagnosed. Excuse me. The next one is get a treatment plan, and then the next one is follow that treatment plan. And that treatment plan is going to be the key to success in the physical health agenda. Lisa Mangle, you were there at the start of these discussions in America last year. Where are we taking things, do you think, with this agenda going forward?
I think what we're doing as a company is we're focusing on below the neck. So a lot of our baseline measures are looking at things like sleep, things like alcohol use, nicotine use, anxiety, all the things that come along with ADHD. We're actually observing those, and then we're looking at those when we've optimized treatment. And one of the questions, Phil, was around are the ADHD meds designed to increase dopamine? So the answer to that is yes. And the problem with ADHD is that there's a lack of dopamine in the bit of the brain that we need dopamine to be in for us to focus, concentrate, and not be impulsive. And, sometimes people are using substances to feed that dopamine and get an immediate release hit of dopamine, but it's very short-lived. So what we want to do is to, as Phil said, get the right diagnosis, but optimize our patients. We don't want them to be just a little bit improved, just to see a bit of improvement. We want them to be the best version of them possible. So we are treating with medicine to optimize that dopamine level. So it is exactly where it needs to be, not too low, not too high so that you're getting side effects. It needs to be exactly where it needs to be for that patient. So all our patients are on different doses of different medications. And I think what's really important is that when you're setting your goals, you're thinking about below the neck. So I don't know if there's patients on here who have not got a diagnosis and are fighting with the GP to actually get a referral or to go through the right to choose process or whatever. but actually going to your GP and saying, look, I've done this webinar that's talked about the other things that come along with ADHD, such as binge eating, obesity, type 2 diabetes, sleep problems, increased alcohol, nicotine. These are the things I'm struggling with alongside what I think are ADHD symptoms, and it's having a negative impact on my health. Please refer me, because it's not just about me, it's about the bigger picture. And I think if you can gather that evidence to take to your GP, you know, monitor exactly what's going on with your physical health, then I think you've got a better chance of being listened to. So yeah.
Let me pick up a couple of questions, and then I'm going to come to Lisa Collins for an overall picture of your view of this, Lisa, in the wider perspective. Let me pick up a couple of questions as Lisa's getting ready for that. There's a question about is contact with the clinic every 3 weeks enough? I think that's a great question. It can easily be answered in terms of, gosh, I wish we could be in contact more. But let's put that into the context of the overall national picture. Contact with your clinician every 3 weeks, which is the plan. I'm going to tell you now, we've had challenges with that with the medication shortages. But clinical contact every 3 weeks is a phenomenal performance by our organisation. I would desperately ask you to look at, you know, other clinics that are 6 months apart in these things, not a matter of weeks. But of course, what you can and should do is avail yourself of the power hours that are provided on a very regular basis, 2 or 3 a week, and they're all on subjects that are related to the agenda we're talking about tonight. And we publicise those a heck of a lot through social media. A lot of them are free. And that's the motivation to keep going. That's the motivation to keep learning about yourself, keep listening, and keep on your treatment plan. The next part of that, which is a separate question, which is about motivation itself. And we know that people with ADHD can have this hyperfocus. Whether that hyperfocus is fully functional or dysfunctional, I think is often questionable. If the hyperfocus is because we've got something to do, we've now got to the panic because we procrastinated for so long, we've now got to hyperfocus at the expense of everything else to get something done. I'm not sure that's healthy, and I damn well know that's not sustainable forever. If the hyperfocus is actually detuned a little bit and it becomes something of passion, of a hobby, of an interest that can drive us to be a better person, drive us into doing something more positive, then we're on a different pathway. People with ADHD thrive off addiction. Now, Lisa Collins has talked about addiction in chemical addiction and how that can get people into a prison life. But if that addiction was to something positive, walking the dog every day, basket weaving, it doesn't matter. But if that addiction was something positive, and particularly linked to positive outcomes of feeling well about yourself, physical exercise, and if that passion became not an addiction, but became something that was positively enjoyable, we still get the little dopamine hit from doing something that we are, quote unquote, addicted to, but we turn that to a positive. We had an internal training seminar in January with a man called Professor Robert Brooks from America. And for those of you studying who want to study and have an interest in the psychology of ADHD and autism, Bob Brooks is one of the world's leading experts. And he was saying, for all of us, we need to find our island of competence. And if we can find our island of competence, we become happier and better people. And for our children, finding what is it they're good at and what is it they're passionate about, that will change their lives. And if we do that, we can actually prevent some of these physical health syndromes. We can prevent some of the ADHD below the neck happening because we're producing happier people anyway. So there's an awful lot of correlation between all of the things we talk about and the physical life below the neck that we can change and should change. Lisa Collins, if we broaden your perspective for a second as an ADHD clinician and as one of our team leaders, what are you finding in this regard of ADHD below the neck on a regular daily basis, as it were?
It's incredible the changes I'm seeing in people every day in terms of people that are on the right treatment plan. So I'm seeing daily people that are feeling calmer, better mental health, increased self-esteem, more productive, people with reduced or no substance misuse, like Lisa said about the alcohol. So it's either reduced or it's completely stopped. I'm noticing patients that maybe previously couldn't stop once they started drinking alcohol, whereas now they're able to just have a glass of wine with dinner and be sociable, but that's where it stops. People just feeling like they're listening better, they're becoming better socially. We're seeing people that now have the ability to exercise, where before motivation's just not been there. So they're getting those increased dopamine hits that Phil was speaking about. It's just the whole holistic picture. I'm seeing massive changes on a daily basis. It brings me a lot of joy.
Yeah, I remember a couple of years ago, in a training session for our staff, the trainer, the external guy, Jack Riggs, went around the room, introduced yourself, and tell us what you do within the organisation. We got to Rebecca Whelan, who said, "I save people's lives." And I remember sitting back and thinking, "Well, that's quite powerful." And talking about it, and Jack picked it up and talked. She says, "Look, this ADHD thing isn't about young boys throwing a chair at a teacher in school because they don't want to get caught out in an exam. We are changing people's lives." And that go right back to the grenade at the start, the 13 years statistically, less lifespan unless we get this stuff right, this below the neck stuff. And Lisa, it was still, I'd never asked that question of you or discussed that with you previously, that you're seeing that reward from what our treatment for ADHD can give.
Yeah, every day.
And you know, people said at the start, what are the tips? The tips are follow your treatment plan, because this stuff starts to fall into line then. And then where your clinicians are saying, cut down the caffeine, let's get you off the smoking, let's get your exercise. There was a great question here about what's the right exercise? Well, the answer to that is it doesn't matter as long as you start to get some exercise. You know, it could be it could literally be doing some of that middle-aged man stuff that you see on social media about the cardio exercise from your armchair. It could be walking the dog, it could be swimming, cycling, whatever you do it safely, do it well, and just improve daily. Do that little bit more. It does make a difference. It really does. This could be a practice what you preach exercise, and I could be really put down by my family. I'm not the most exercise-driven man in the planet at all, but I know that when I'm working at conferences or I notice my steps have gone up, and I actually feel tired when I go to bed, and I actually feel that little bit of physical exhaustion as opposed to mental exhaustion, and I actually feel better for that. It's quite a bizarre feeling that I've had that exercise and I've done that little bit more. I don't take caffeine. I very rarely take caffeine. When I do, I notice the negative effect it has on me. These are things that we can control. And to keep that grenade going in the pond, this can extend your life.
Yeah.
And what have you got, Lisa?
I was just someone's asked about coaching and counselling, so I'm not just going to go there just yet, but went on to say that medicine's not always an option because they can't afford to go privately. So if you live in England, you do have the right to choose. So you can go on our website, print off the right to choose documents, and take it to your GP and get a referral under right to choose. And you're essentially an NHS patient at that point. And our right to choose waiting list is under a month. So, you know, there are options there. And you do have the right to choose.
Yeah, let me pick up on that, Lisa, if I can, because there's another comment in the comment box which I'm going to go back to. First of all, the comment is my GP said they're not offering it. I presume that's in relation to right to choose. Your GP hasn't got a bloody choice; they have to offer it, and we are under license to provide right to choose for adults, and we'll be moving into 14+ in the not too distant future. So East Riding of Yorkshire can take our paperwork and use it as a suppository. They have no choice. They have to offer you right to choose. And we need to be very clear on that. If we go back to coming off something that doesn't get me as passionately wound up as GPs thinking they've got control over something that's national statute, I was having a discussion with a mum about her her teenage son yesterday, and she was saying that she's struggling to find the right medication for him. And maybe he's one of those that can't tolerate medication at all. I find that really rare. And what we often find is we've got to probe that a little bit more and try and work out what the hell's going on. And I probed it. And what we found was that the young man had lost a significant amount of weight by going on the medication. And the weight loss from that medication was there, and mum didn't like it. I asked the question, that medication at that dose, what was the effect on his ADHD and his overall lifestyle? He loved it. He was really happy. He was doing better in school. He was keeping his friends. He was actually much, much happier. But mum was intervening because her son had lost weight. So my question and my challenge back to mum was, well, what's the greater risk to this young man? Him being thinner or him being unhappy and not achieving and not getting through to where he wants to in terms of his potential? Now, that's a pretty tough conversation to have with any mum, but it was the conversation that needed to be had at that moment. And sometimes we as a team have to have those difficult conversations.
Yeah.
And we have to go to places where you may not want to tread for all of the valid reasons. But we need to be very, very clear that treatment for ADHD is not just about getting the 3 R's right. There is a physical health link to this, and we can provide better outcomes for people across the board by doing this. Lisa Mangle, were you going to say something then?
I've forgotten now. I've got distracted. I've got distracted by the next question. Yes, we do right to choose. Is the thing I was reading.
We do provide right to choose.
I know what I was going to say. Sorry. So I was reviewing a child this week who, when we review children, we not only do their observations, but we plot them on a centile chart. So when I looked at his centile chart, I did his weight first. So he'd gone from, I think, the 75th centile for weight down to the 25th centile for weight over a long period of time. So that worried me. But then I plotted his height, and his height was the 25th centile. So he should have been on the 25th centile for weight, but he was clearly a binge eater, like a lot of adults are. And I think it's about looking at that bigger picture and having that conversation with parents too, sensitively, obviously, to why I'm not as concerned as they might be about the weight loss, so long as they're having a really good breakfast and eating some lunch and having the main meal in the evening and have supper if they've not had, as much to eat at lunchtime as possible. But it's about looking at the bigger picture and managing those what looked like potential side effects when actually he just stopped binge eating and was eating normally, and was now a healthy weight for his height. But I got distracted by, do we do right to choose? Yes, we do. So,
there's a question about height and weight, and we need to do another webinar on myth busting soon, I think, because the myths come back. It's a bit like a game of whack-a-mole. You push them away and then they tend to come back, and social media feeds myths and what have you. I'll come to you, Lisa. There's one about is there any link with stunted growth in growing children? No. There is no long-term evidence whatsoever that the taking of ADHD medication leads to stunted growth at all. Now, that's the scientific fact. I would qualify that and say, there's the facts. But if your child was 4 millimeters less in height than another child at the same age on the same pathway with the same lifestyle, but was really happy and able to achieve their potential, what are we giving up for what gain? And we have to be there is no science that says stunted growth is there, but the myth tends to suggest it is. Well, it isn't. But if it were, at what cost? And we have to be very careful about that. What were you going to say, Lisa?
So it was to that point, really. So I worked in ADHD for 22 years, and I've had kids over the years where I've thought, well, they're not growing as much as I'd like them to. But then they walk in when they're 15 and they're 6'2", and you think, why did I worry? Yes, occasionally I might be concerned about someone's growth to the point that I've referred them to a dietitian, but that is occasionally. Providing you're doing the treat your breakfast as an all-inclusive hotel breakfast, not just a quick snack like British people tend to do, you know, and have the main meal in the evening when the meds have worn off, and have supper and just get those calories in, then I'm not concerned. The other thing that people don't realise is that growth hormone is produced at night. So if you've got a kid who's got ADHD untreated, got this busy brain, not sleeping, then they're more likely to have a growth problem because they're not sleeping, because that growth hormone is produced when they're asleep. So, you know, but the thing is, you know, we monitor that, you know, we're monitoring that every 3 weeks, we're plotting it, you know, as clinicians, as parents. If your children don't eat as much as you want them to do, you worry. But as clinicians, we're looking at it from a very different perspective. And we've got good tips and tricks on small amounts but high calorific food, so we can give you that advice if you need to.
I'm going to come back to both of you to close out in terms of what's your top tip for the physical health of the person with ADHD, to take that below the neck and give you a top tip. I'm going to come to you in a second. As just before I do, I'm just going to address something. I think Lisa Mangle said right to choose weight is 4 weeks. It is slightly longer than that, and I don't want anyone to leave this webinar with that, but it's nowhere near a problem. It's still very, very quick. It flexes and wanes on an almost daily basis with the demand being placed upon us. I think last month we assessed 700 patients under right to choose. So it does flex and it does wax and wane a little bit. And can say that. Someone's asked us what the 3 R's are: reading, writing, and arithmetic. It's an old-fashioned saying. I'm a dad, I'm an old man. I still refer to old expressions every now and again, forgive me. I'm going to give you my top tip for physical health, below an ADHD below the neck, in a second. But if I went to Lisa Mangle first, Lisa, what would your top tip be?
I think for me, it's about optimizing treatment. You know, if we look at that 13 years, that's quite horrific, isn't it? And the quality of life of someone with poorly managed ADHD is as poor as someone with type 2 diabetes. So for me, it's getting the right medicine, getting the right dose, optimize the waking day, not the working day, so that we can really get someone's life on point. And then you're more likely to hit all those quality of life tasks, like, you know, going to the gym and socializing and laughing and being happy. And, you know, for me, that's really important, that someone's happy. You know, and the quality of life and the below the neck will improve if we can get the treatment right. So that's my top tip.
Thanks for that. And Lisa Collins, what would your top tip be?
So obviously I agree with Lisa M. My top tip, I think, is there was a research paper not long ago about the benefits of walking. It says that it was, I think, 20 minutes 3 times a week of fast-ish pace walking are more effective than an antidepressant. So I think just in terms of getting that dopamine hit and feeling better, I think if people can get some steps in, then brilliant.
Excellent. And my top tip for below the neck is, I think is relatively straightforward for everybody, and that is stop smoking, and just watch the health benefits and the financial benefits. And the key to that is, for people with ADHD, have your assessment, get your diagnosis, get your treatments on plan, go for a walk, and break the habit of, whenever I do this, I need that. Whenever I used to have a habit I was diagnosed with diabetes 2 years ago, and whenever I sit down to watch the telly, I used to eat sweets. I don't now because I can't. These habits are what we need to break. So to actually achieve the physical health benefit, have your assessment, have your diagnosis, follow your treatment plan. We've had some great questions from a tremendous audience. I would like to thank Lisa Mangle and Lisa Collins for giving up an hour of their time this evening after a busy day in clinic. I know it's hard and I know it's tough. but we are doing the right thing for people as a clinic. I'll round out by saying we're coming through the international medication shortage now. We're seeing a light at the end of the tunnel. We switch pharmacy provider in 2 weeks, and that's going to have a big change for everybody. Thank you for everybody for bearing with us through that. We're one of the only scaled up clinics that have kept treating people. The guidance from the NHS was to not treat, and we've kept treating, and we're proud that we have, but it's been bloody hard work. But thank you for your patience, and thank you for making things work. Thanks for coming tonight. The marketing team and Kristen, thank you for pulling this together. As always, it's gone in a heartbeat. Thank you for the agenda that's come out of the questions, and let's see where we go next with this campaign over 2024 as we address ADHD below the neck. If I could ask you all to jump off the webinar, and we as a team will just have a quick debrief, and we'll take it from there. So thank you on behalf of us all.